This, I guess, is for Dr. Vez, just on the post-traumatic patient that had the syrinx that you said there's really nothing you can do. I mean, was there nothing that you did for that patient, or I guess what's kind of the prognosis there?
No, that's a great question. And I'm glad you clarified that, because I think in the beginning of my talk, that patient very much fell into the patient that needs help and needs your coordination, and not just, it's not surgical. I didn't do anything surgically. So that to me is not a surgical lesion. That patient absolutely needed to be in the right hands, because that's out of a primary care, in the best of primary care physicians or healthcare providers' hands. That's a much more complex thing that needs to be quarterbacked. So what I did do is, and I follow that patient every year with imaging and more frequently as they need help with things, but we basically got them on an appropriate drug regimen, because someone put them on opioids, which was a disaster, and injections don't tend to help. So we got them on the right cocktail with a brilliant pain med doc, essentially of gabapentin. And we got to a dose where it really took the debilitating pain away. So that patient was fortunate with that, because he did have a recommendation of a shunt, of putting a little tube in there. So, but it is a lesion that is a neurosurgical lesion. So I follow it, but even though my recommendation is not for surgery.
Question. So post decompression surgery, if there's a large syrinx that persists, do you ever recommend something else like a shunt? And also, what is your opinion if there is a shunt and there's a quick decompression after that? Would it cause any problems that maybe were not there before, like pain or anything else? Like, what are the risks of doing that?
So shunt of the syrinx, or shunting of
the syrinx? Yes. Is that an option?
It is an option, but I think, and I love to hear from my colleagues as well, I think it's falling more and more out of favor. I think the older people like myself were trained where we did a lot of them, because that was the mainstay of treatment. And it is very clear that these patients didn't do well. The ones that it would decompress, they would be back very short term, because it's a very low pressure system. There's not enough pressure to keep that tube open. It clots off and it comes back. And every time you go back in, you're dealing with a spinal cord that's the size of a quarter, with some very important fibers and pathways and nerves going through there, or tracks, I should say. So every time you go through there, you develop scar tissue. It is not a benign procedure. But to get back to your first question is, again, we said the majority of the syrinxes will, if they're related to the Chiari, will resolve both radiographically and clinically. But it's not uncommon where you'll see residual syrinx, but the symptoms go away. And that's the most important thing, because if you have a very large syrinx that's been there for a long time, you've lost compliance of that tissue. So even though it's not under pressure, you'll still see it there radiographically. Now, if the symptoms come back and the syrinx is either getting larger or not changed, then you have to really look at, the first stop is a Cine flow, because it would be very unlikely that there's not some residual blockage of flow. And sometimes it either needs to be expanded. The patients with large syrinx are the ones that I will do a more aggressive decompression with. I won't do the minimal. I'll take more bone off. We'll open things up a little bit more. So I hope that answers your questions.
Hey, Dr. Vez, this is Dr. Lazareff, UCLA. He's asking the question for you. Incidental finding of a Chiari malformation, tonsils down to C1, the patient's asymptomatic. Do you allow the patient to play sports like contact sports, football, and such, hockey, wrestling?
Yeah, so I have two patients. One had a full scholarship to the Air Force Academy, contingent on him playing football, and another college football player that was incidentally diagnosed. And if they are truly asymptomatic, I will allow them to play. But that is true. I mean, even mild headaches to me is symptomatic. And it is at C1, there's no syrinx, I will allow them to play. Syrinx, no. Symptomatic, no.
Yeah.
That's my treatment. But there's as Brian mentioned, there's I don't think there's a right answer.
Because I actually had that case and I did the surgery. and he had a good career even in the NFL. But I chickened out. I didn't have the certainty. He was insistent on doing football, so I said, okay, we'll do the decompression.
Yeah, I wouldn't call it checking out. I think what you're doing is doing the best thing for the patient. And I think it becomes, and believe me, don't think that I didn't lose sleep thinking, my God, if something happens to these poor kids, even if it's unrelated and, they get, but I think at some point it comes into the making sure that the patient understands, no one can say there's zero risk. And can I tell you, but this is an experience. This is the data. This is, why we're considering this. It's the same thing with giving birth. I really changed and got a little bit more less conservative when we do have good data on pregnant women. And it really fits that. Syrinx, symptomatic C-section versus a vaginal delivery. And without those, you can do that. And that, to me, that valve-salving and constant pushing worries me a little bit more than, this kind of concussive hit.
Yeah, those are all great points. Here you go. Another question.
For anyone, with my Chiari, I had a 13 millimeter herniation. Do you remember?
Yep.
And then, so now then I have two daughters. One of them has a 3 millimeter, what do they call it? Just a...
Yeah, tonsillectopia. Some people call that.
Tonsillar ectopia. And so that's what I look at when you talk about like pregnancy, and then you talk about, they're not into sports or anything, but back when I was 18, I had a whiplash. I had a rear-ended accident. So I wondered whether that created more of my, you just start thinking of all these things. What created where I'm at now? And is it something that I tell them, keep an eye out for it, watch for this, watch for that.
There is a CSI episode on that.
Yeah, I always, that's another question. Is it familial? And study here in ASAP years ago, right? It's like 10% in families. But there are cases like I have multiple families where there's, the brother, sister. It is, clearly genetic, or mother, daughter. I've had mother, son. So anyone with Chiari in the family, I say if they have symptoms of Chiari, headaches, the typical list we talked about, the swallowing problems and balance problems and so forth, then we should get an MRI, right? There's no question about it. Get an MRI and we'll look at it. And that's like always a constant question. And, so.
Yeah, I agree with everything that was said.
Other questions?
Do you often see people that have memory loss after the decompression, if they had a Chiari and the Syrinx?
So the question is the before, and I think I can speak for all my colleagues. We do see it a lot, but it's really what is the cause of it. And so we recently started really collecting data, and we absolutely are seeing people that are improving after the memory based on, again, this is a limited memory test that we're doing, but subjectively from the patients as well. What we don't know is it the stress and, the symptoms are better. They're, back to a better lifestyle, because we do know stress and the chemical response that the body and the brain release does affect memory. So, it's a cause and effect. But what we ultimately want to do, and we're trying to get a grant for now, is that imaging we showed you is a pre and post, because that will then answer it if this is a true anatomic improvement after a decompression. But to answer your question, yes, we see many of our patients that the memory improves after, and it's usually in severe Chiaris. And that's one of their bigger complaints.
This question most likely is for Dr. Dlouhy and possibly Dr. Vez as well. When you perform a fusion, and you decide that you also need to do a decompression, which I assume that's a decision you make on the spot. Does that complicate the surgery, and to what extent? And also, how does that affect the recovery time?
When we do a fusion for a Chiari, we go into with the idea we're going to do a fusion and a decompression at the same time. It does, the way I do it is patients are in traction like you saw, and the head is maneuverable because the difficult part is you want to make the alignment normal, but to do the decompression, they have to be slightly flexed because you have to get in from the back. And so the head's flexed during the decompression, and then we can maneuver it a little bit more normal alignment when we do the actual final positioning for fusion. And that's after we do the traction, realign the bones are out of alignment, right? Take away the vascular invagination, the distraction, that's the instrumentation. So that does make it's a longer surgery. Instead of being like, 2.5 hours or 2 to 4 hours for like a decompression, you're talking more like, 4 or 5 hours, that kind of thing, or 4 to 6 hours, that kind of range. And they're probably in the hospital a little bit longer, maybe, I think from ours, maybe like a day or two longer. But it doesn't necessarily make it a longer recovery, really. I do keep them in a cervical collar, and they have to stay in that for months after surgery. But so that will make it a little bit longer recovery from that perspective. But they're pretty similar.
Yeah, I agree. That decision is always made preoperatively with preoperative imaging and signs, symptoms, and all that. There would be a determination of fusion. And I don't know in the adult population, and maybe it may be selection bias on my part or referral bias. I would say the great minority of my patients end up needing fusions as well.
Yeah, I agree. It's not common, right?
But clearly there and at times very necessary.
Yep. Other questions? One more here.
Just as we kind of look at the advancement of technology, I guess, where are we at with any implementation of AI? Is that years down the road? Would that even be applicable for some diagnostic reasons, or where are we at on that?
Dr. Zhao.
Great. Thank you for the question. Well, it's hard to imagine nowadays things without AI, and but I would say that I completely agree with all the other speakers that we should really consider the symptoms of our patients before building or implementing any AI algorithms. That is why nowadays in the medical AI community, there is a growing trend or a growing trend on incorporating patient symptoms or even lifestyle factors to better or to improve diagnostics or make more accurate predictions. Because, for example, in the past couple of years, we have built various systems in making the MRI scans more accurate or less noisy or shorter and quicker with less contrast agents. But we often forget what's the most important, which is the symptom or perhaps the quality of life for our patients. Therefore, nowadays, there's more and more interest and need for us to integrate different data in a multi-modal fashion to better implement AI systems for outcome predictions. So as far as I know, last year in around August, there was actually an announcement from the NIH on just seeking ideas or gathering thoughts, brainstorming on how we can make next generation AI systems to better suit our patients' need, and how we could integrate different types of data for outcomes predictions. Therefore, this is a very interesting question, a very important question, and it seems to be our national priority for the next couple of years.
I would like to add to this. I mean, I fully agree with you, but we also have to increase or expand the education of the doctor or the physician who interprets that AI. No? If you have AI, I put it in Spanish. So you have a volume of data, right? But you don't necessarily have knowledge, and you don't necessarily have understanding, and much less insight, no? And the ability to understand that volume of data comes with experience, of course. I mean, absolutely, as you all know, a physician of 20 years experience is much better than a 10 years experience. There's no junior resident here, but I mean, we know that. And so the education, the human understanding of the physician has to be also a factor, no? Otherwise, it's data.
Yeah, I would echo that. I think that's a really important point, and I hope that we don't go down that path, because I think we're going to learn a lot of lessons at patients' expense from that. I would say one of the things that I think is going to be a role with AI is more of the diagnostic component, not the telling us this patient has a Chiari and needs surgery or not, but helping differentiate some of these clinical symptoms. And one of the things we started using for our normal pressure hydrocephalus patients and Parkinson's patients is virtual reality. There's several platforms now with the goggles that can actually take data points and differentiate between central, peripheral, if somebody's ataxic, where is it coming from based on different tasks that they need to do. But I think, again, getting to that same point, it's taking that data, much like a Cine flow or something, and using it as a tool for your overall decision-making process and really diagnosis.
Thanks, Dr. Vez. Other questions? I think we are good. Well, thank you, guys. Thank you so much. Thanks, Dr. Vez.
Thank you. Thanks, Brian. I owe you one, and we'll see you guys all next year.